So I'm Kevin Johns. I'm the cancer psychiatrist at the Ohio State University James Comprehensive Cancer Center. I work there helping our oncologists with taking care of the behavioral health needs of our cancer patients. I think I had the opportunity to meet some of you yesterday during our burnout talk, and I'm glad to be back today and to see you guys and the new faces as well. Today I have my colleague with me, Dr. Helen Rempala. I'll let her introduce herself.
So I'm a clinical psychologist. We work at the same department. I specialize in sleep and adult type of ADHD, but I also obviously deal with psychologist's bread and butter, which is depression and anxiety.
So today we'll be talking about depression and anxiety, very common and important issues in cancer survivorship, including Waldenstrom's. So our objectives today, we're going to work on understanding depression, anxiety, and how they impact cancer care, and then understand some coping strategies for managing depression and anxiety, and then also talk about some options for professional treatment of depression and anxiety.
Okay, so we start with the premise that all emotions are adaptive. They make us human, right? So I'm going to introduce you to something that we called three-component theory of emotions. That every emotion has a cognitive component. It's a response to something that we perceive. It has physiological component. It makes us feel a certain way in our bodies. And it has a behavioral component. It makes us want to do something. There's a specific urge to do something that comes with each emotion that our colleagues in the psychology of emotions and motivations identified. Okay, so let's talk about depressed mood. We really could call it sadness. Can you tell me, guys, when do you feel sad? When what happens? When there's some kind of a loss, right? When you lose your health, when you lose your loved ones, but also when you lose, I don't know, an award or a job, or expectations didn't go the way they should. So depressed mood can just start as sadness. And we will take you today from this sadness all the way to what can go wrong. But sadness itself is a very important emotion. It's a response to loss. It wants us to slow down. It's very heavy, right? When we feel sad, it's not like we, are ready to go dancing. And it wants us to withdraw. Now, do you have a guess? Why would it want us to withdraw? When we're sad, we're kind of like not into particularly happy, social mood. The research tells us that it's probably because we are supposed to ponder and acknowledge the loss. So that's what I wanted to say about the sadness, depressed mood. It can go obviously too long. And if it will go too long, it will make us withdraw for too long. It will make us lonely. It will affect eventually our body, because we kind of will stop doing much, and we'll just lay in bed sometimes. And it will start interfering with our lives. So that was depression. Actually, it was depressed mood, not yet depression, just sadness. What about anxiety? What do you think the anxiety is a response to? It's kind of on the slide. What do you think? The unknown, the unexpected. Anxiety is a response to uncertainty. I don't know what's going to happen. And how do you feel when you feel anxious? It's pretty activating, right? There's this energy that we want to do something with it. And what do we want to do with it? We want to plan and prepare. So the adaptive, healthy response that we call anxiety pushes us to plan and prepare. Too much planning and preparing we start going crazy, right? We start checking and rechecking, and did I pack this? Did I check this? Let's just see if how many medication do I have? Did I take them all? This is morning box, this is afternoon box, right? So there's more and more of it. But planning and preparing is built into our human response to uncertainty. When planning and preparing becomes excessive, we start talking about anxiety becoming a disorder. But some of it is normal. It's adaptive. There's a little warning here, right? Anxiety is not fear. What is a fear a response to? It's also here. Danger, mortal danger. The fear is a response to truly something dangerous. Very activating, right? If we let it go, it may actually turn into panic. And what is the behavior that is built into fear? The famous flight, fight, or freeze, right? This is the behavior that is built into fear. So we're going from anxiety, which is a good adaptive emotion that helps us to plan and prepare, because we should plan and prepare for something, when we are uncertain. And if it becomes too overwhelming, too frequent, then it may become something that we would call a disorder. I did put a fawn reaction because this is our new thing in psychology: fight, flight, freeze, or fawn. But it's a different topic. We are not going to talk about it. So again, fear is fear usually, it's a healthy emotion. It allows us to survive. If it goes too far, and if it occurs in response to uncertainty, then it's not good. For uncertainty, let's just plan and prepare. For danger, we should run away or get into fighting. Any questions on this? What about other emotions, right? Well, we're not going to cover them, but they're all very adaptive, and they all have a behavioral component built into them.
All right. So thank you. So, we talked about anxiety and depression, both very adaptive, normal emotions. But when they go too far, they can definitely impact people's minds and their bodies. And this is, very true for, virtually any medical illness that has been studied. For example, people with major depression are more likely to have heart disease. People with diabetes and depression, they're more likely to develop, neuropathy, renal problems. And so I tell people that, things like depressive disorders, anxiety disorders, they're not just in your head, they affect your entire body. And they absolutely intersect with all these other medical illnesses that people are trying to, manage and navigate. And cancer is no exception. Unfortunately, when people who are diagnosed with cancer, or any time that there is, a change in the treatment plan, a recurrence, even finishing treatment, those are actually very vulnerable times, and people are at higher risk for developing depressive disorders. And interestingly, about half of the cases of clinical depression that we see in cancer survivors are actually in people with no previous history of depression. And then similar with anxiety disorders, we see that the prevalence, or how common it is much more elevated above, kind of the general population. And we see, between 15 and 20% in men and 28 to 34% in women. With certain types of cancers tend to have higher risks of anxiety and depression, but by and large, all types of cancers, including blood cancers, are a risk factor. And so, kind of going back to this idea that, major depressive disorder and anxiety disorders, they're, conditions that affect your entire body, and they can unfortunately be associated with very real changes in terms of people's cancer treatment outcomes. Patients with major depressive disorder or anxiety disorders, they're more likely to have poorer quality of life. they're more likely to have difficulty sticking with their cancer treatments or finishing their cancer treatments. They're more likely to say, I can't tolerate the side effects of this treatment, or I can't finish it. If they have to be admitted to the hospital, unfortunately, people with depression and anxiety, they're more likely to have a longer hospital stay compared to cancer survivors that don't have depression and anxiety. Um, and then unfortunately, patients with depression and anxiety who have cancer, they also tend to report a greater wish for hastened death, wish that, it could all just be over, or wish that the disease would just take its course and take my life. We view this as being, related to but separate from the idea of suicidal ideation or the wish to take one's own life, but it's still very concerning and, a marker of, the suffering that people are carrying as they're going through cancer survivorship. And then, unfortunately, people with depression, anxiety, and cancer are also at a higher risk for death from suicide. And that's, a tragic outcome that, we always try our best to prevent. But unfortunately, cancer patients, even years after their diagnosis, they are at higher risk for suicide than the general population. And, there's unfortunately, there's a lot of stigma around, suicide and talking about suicide in our society, but I, really encourage people to think of it as, a complication of a medical condition, including cancer, and seeking medical treatment if you or a loved one are struggling with suicidal thoughts. We have you can always call 911 or go to the ED. A lot of communities have crisis centers. There's the 988 suicide hotline. So there's lots of ways to kind of access crisis support when needed. And then, also, we talked about this yesterday during our burnout session, but, anxiety, depression, psychological stress, all these things can also impact sleep. And then poor sleep then can impact all your other health issues too. And so it becomes this vicious cycle, right? And so, really the kind of overall message I try to help people understand, both, patients and other doctors, is that depression and anxiety, it's not just in your head. This is something that is a condition that affects your entire body. And it's important, I tell people, if you have depression, if you have anxiety, like treating your depression and anxiety is actually a really important part of your cancer treatment plan. Or, in someone with heart disease, like treating your depression or anxiety is a really important part of your heart disease treatment plan, because the mind and body are connected in, ways that we don't fully understand. And it's a very powerful connection. And it's important that we, as both, patients and healthcare providers, that we acknowledge that connection. And then unfortunately, there's much less conclusive evidence in terms of how treatment of depression, anxiety in cancer patients helps overall outcomes. But we do see that when people with cancer do get depression and anxiety treatment, the research has shown that quality of life does increase, and they also have an increased chance of completing cancer treatment. And just from, my clinical experience of working with cancer survivors, like I can tell you that, that's the value of treating someone's depression and anxiety is priceless, even if we don't necessarily have like the randomized controlled trials that show it, just from, the patients I know and the stories I've heard, this is something that's, immensely important to survivorship.
So before we're going to go into, how to address anxiety, depression, whether it's just sadness and a little bit of uncertainty, or actually clinical issues, I wanted to show you a little bit of a good news. These are cancer patients studied in Germany. I forgot how many we had of them, probably around 200 or 230, if I remember correctly. In blue, you see cancer patients. In red, you see matched controls. And I would like to point your attention to the very first square. This is a quality of life, the overall quality of life. And it starts with the treatment, and then we have a 1-year follow-up, and then 5-year follow-up. Interestingly, the quality of life of cancer survivors improves in about a year after treatment. And if you talk to cancer survivors, they will tell you, that we start appreciating life more, then we start taking care of ourselves better. Sometimes we need to go and get some treatment. We reach out to people. Basically, we start prioritizing what's important to us. The other square that I would like to point your attention to is what we're talking about today, the emotional functioning. And this was basically depression and anxiety questionnaires. Same story, right? It's hard to be diagnosed. The treatment is initially hard, but as we survive, well, that's what happens. It's coming back to the baseline. Um, I could not tell you that what is not, that's fatigue. It also comes back to that to the baseline. But what is not improving is sleep. So sometimes if you experience sleep problems before your diagnosis, you probably will also experience it later. So it's worth to get treatment for it, because treatment for sleep works regardless how old you are. And another thing that doesn't tend to improve as much is our cognitive functioning, unfortunately. So it's a good news in terms of emotional functioning. It's not such a good news when it comes to our cognitive sharpness, at least not within the 5-year follow-up. So now let's move to coping. Is it still me? It's still me, right? Okay. So how to cope before we even get and seek professional help? Depression. Well, let's go back to what I said at the beginning. What is it a reaction to? A loss. Let's acknowledge the loss. Let's talk about it. Let's acknowledge. Let's have a moment. Give ourselves a moment to grieve. Figure out what keeps you from reaching out, from going to this party, from going for tea with your friends. Do not deny it, but also don't catastrophize it. We'll talk about it in a second. And for anxiety, well, plan and prepare, but watch out. Plan and prepare for what you can control. Because if you start planning what you cannot control, well, obviously that will become a problem. And you will get into a rabbit hole of trying to control the uncontrollable. Obviously, you're talking to a sleep psychologist. Get some sleep. It always helps. And at some point, you may want to consider consulting a specialist. And what we recommend most often is cognitive behavioral therapy for either depression or anxiety or just emotional regulation.
Yep. All right. So, definitely these things are depression, anxiety, they exist on a spectrum. They're very normal experiences, but they can go all the way to the far end and become, illnesses that affect the entire body. And so, one of the challenges, though, is that because these are part of normal day-to-day human life, human experience, it can be hard to know when to ask for help. Because we certainly don't want to take away all of people's emotions. We want people to feel sad appropriately when they have a loss. We want people to feel appropriately anxious to help them prepare for upcoming stressors. And so our goal is never to eliminate all emotions, right? And so, when I tell people in terms of like, when things become abnormal, it really comes down to, is it not going away? And also, is it affecting your day-to-day functioning? So for example, like if someone has, signs that someone may be developing a major depressive disorder, they may feel sad all the time, not just when they think about something sad happening, but it's, almost every day, almost all day. And then, in addition, when something good happens, they don't feel joy from it. Right. So if you were here yesterday, we talked about demoralization and how when people are demoralized when facing, serious medical conditions, they can feel hopeless and helpless, pessimistic. But typically, if, a loved one comes in to visit them or they get good news about their most recent lab report, usually they can still light up. And, if they have an opportunity to engage in, a favorite hobby, they can still, their face still lights up. They still feel that joy from that. When things when someone is not able to feel that positive emotion, even when something good is happening amidst, all these challenges, that's when we really start to get worried about a major depressive episode. And kind of the clinical term we use is called anhedonia, so a lack of ability to experience joy. Um, the major depressive disorder or major depressive episodes is also associated with changes in how we think. So, when people are depressed, they're much more likely to focus on the negative, and change thought patterns such that, they start to think that they are worthless. And it becomes more than just about, this illness is bad and I've lost so much from the illness, but also it's become more global and become thoughts of I am worthless, or there's no hope at all for me, or I've lost all meaning in life. And so when those kind of negative thoughts expand beyond the illness itself, but kind of spilling over into other parts of our identity, that's another clue that, this might be more than just normal sadness in response to an illness, but becoming more of a depressive disorder. Um, Similar, like I said before, major depression, clinical depression, and anxiety disorders, these are things that affect your entire body. And so, when people have clinical depression, they can actually have physiological changes that actually kind of resemble like flu-like symptoms. Like if you think about how you feel when you have the flu, you're feverish, everything hurts, you don't want to move, your appetite sucks, you just want to lay in bed and curl up and under the blankets. Really severe clinical depression can actually kind of generate a similar physiological response. People can sometimes, a lot of times they don't eat and they might lose weight, or other times people might stress eat, emotional eating, and then lead to weight gain. It can cause disruptions in sleep. So it can cause you to have trouble falling asleep, cause you to have trouble staying asleep, make sleep less restorative, can absolutely affect your energy levels, and also present with like just kind of your overall activity level. It can cause you to be either really restless, like if you're really anxious and keyed up, or you might just want to just like lay around and not do anything. Um, and the definition of a major depressive episode also stipulates that the episode should last at least 2 weeks or more for it to be considered like a major depressive episode or clinical depression. And also that it should interferes with daily life. So for example, work, school, relationships. So this isn't just, sadness or anxiety that's affecting you. It's affecting, your function in your family, in society. It's affecting your ability to, get along with coworkers or get things done at work. It's affecting your, relationships with your kids. Those are things that we look for when we try to help decide, like, hey, is this kind of normal sadness or grief after a loss, or, is this becoming something more like clinical depression? And so, I think, Helena, yep, yeah. So, Helena, did you have anything else to add to that?
You mentioned thoughts about suicide and hastening death, and Kevin really emphasizes the mind-body connection. We actually can see on the brain scans of people that are thinking actively about suicide and thinking, well, my loved ones would be better off without me. It would be just easier if I wasn't here. We can see the brain shutting down. So when you experience something like this, or you start talking to somebody who is mentioning these thoughts, you can be 100% sure that their brain is affected. The brain stopped considering other alternatives. So just wanted to put it in.
Yeah, thank you for adding that. Absolutely. And so, if you or a loved one, if you think that you might be having, trouble with an anxiety disorder or a depressive disorder, definitely encourage people to get help. It's just, oftentimes I hear people who are facing really tough medical problems like cancer or heart disease. They say like, oh, I can't add on one more appointment to my schedule. I need to, get through cancer treatment first, and then I'll, go see a counselor or things like that. But again, I try to reframe it as, like your depression, your anxiety, these are things that are absolutely affecting your cancer or heart disease or kidney disease. And so taking care of your mind is actually a really important part of taking care of your body. And it's a both and, not an either or. Um, and like I think yesterday we talked about there's a lot of different mental health providers that can help when people are suffering, ranging from counselors, social workers, psychologists like Dr. Rempala, psychiatrists like myself, um, primary care providers, even oncologists, are incorporating depression and anxiety screening into their routine visits. So help can come from a lot of different sources and a lot of different types of professionals. Typically, if you do see a professional for help with depression and anxiety, you should expect a couple things. First, you should expect what we call a diagnostic interview. So that's where they want to, the professional, the mental health professional will essentially ask you to tell your story. They'll take a detailed history of your life, where you came from, the challenges you had growing up, and recent issues, any kind of mental health challenges you've had in the past, and then also incorporating your medical history, right? So your mental health professional will ask about kind of what kinds of medical problems have you had and in the past and currently, so that we can kind of incorporate that into a holistic picture of you that we call kind of the biopsychosocial model, incorporating kind of your internal psychology, your social setting around you and your life story, and also the biology of what's going on in your body. Um, if you see a medical doctor, such as a psychiatrist or a primary care doctor, oncologist, for help with depression and anxiety, you can also expect a physical exam. The purpose of this is to help rule out medical problems that might be contributing to your depression or anxiety symptoms. For example, if someone is having symptoms of panic, like racing heart, we want to make sure it's not a heart problem, right? And we don't want to mislabel that as anxiety, or other things that can often cause depression like symptoms would be like thyroid disease. um, Sleep apnea is actually a really big one. I think, unfortunately, sleep apnea treatment is difficult to stick to because the masks, they are not comfortable. They're loud, and but a lot of people don't realize this, but untreated sleep apnea actually makes it much harder for people to recover from depression. I tell people, if you want your brain to recover from depression or anxiety, you got to make sure your brain gets enough oxygen at night, right? If your brain's not getting enough oxygen at night, it's hard for your brain to feel good and work well during the day. It's hard for your brain to do the work of repairing and recovering from, depressive disorders. So sleep apnea is something that in my practice, I will talk to my patients a lot about. And if they have risk factors for sleep apnea, I will refer them to my sleep medicine colleagues to get a sleep study done. And then, thyroid disease, sometimes some vitamin deficiencies, autoimmune diseases. There's lots of different medical conditions that we sometimes need to work to rule out, depending on that person's unique risk factors. So, in addition to, if you're seeing like a medical provider, like a psychiatrist or primary care doctor, oncologist, et cetera, you can also expect, a medical workup, physical exam, some laboratory blood work. And then lastly, you can expect to collaborate and work with your provider on an individualized treatment plan, right? We know from studies, what works for patients overall, what seems to be effective. But at the end of the day, any treatment plan, in order to be effective for you, it's got to be a plan that's realistic for you and meets your needs and your unique situation and your background, right? And so and treatment can take a lot of different forms. Psychotherapy, such as the cognitive behavioral therapy that Dr. Rempala mentioned, is a very common and very powerful tool for treating depression, anxiety. There's other forms of therapy as well, like acceptance and commitment therapy, psychodynamic therapy. So there's all different kinds of psychotherapies. So for someone who prefers that approach, there's even kind of different options within that, kind of just depending on what your needs are. And then we also have medications. commonly like antidepressant medications. They can be used on their own or in combination with psychotherapy. I almost always recommend a combined approach because I say like medications, they can help with the very real physical symptoms and neurological impacts of depression, but they can't take away the stressors, the losses that you're facing, right? And so even in people where I am prescribing the medications, I will almost always recommend therapy to go along with it. And then also you can expect, talking about lifestyle changes and other integrative approaches. So, if you're here yesterday, we, talked about how I almost always recommend, exercise to almost all of my patients. It's the sleep issues, the cognitive issues that we talked about earlier. Some of the best evidence for addressing, especially like the chemo brain and chemo fog, is actually in exercise. Not a pill, but actually exercise is actually one of our best tools for helping people overcome cancer-related chemo fog or cancer-related fatigue. And exercise can also be a really important part of managing sleep disorders as well. And so, lifestyle changes, healthy diet, those are, all, we try to, take a holistic approach and try to tackle conditions like this from as many angles as we can. Let's see.
All right. That was good. I was thinking about what Stephen said during the previous hour about oxygenation to the brain, right? And you were talking about sleep apnea today, and I'm thinking maybe this particular cancer is, it gives an additional risk here for the need to be screened for sleep apnea. And those masks, the psychologist can help you get used to them. Just don't dismiss it completely right away when you cannot sleep with them. All right, guys. So we were talking about kind of from sadness to major depressive episode, from anxiety to generalized anxiety disorder. So kind of looking at the spectrum. And along the spectrum, also, we have interventions. We have today with us somebody from your foundation, Mary and Grace, who represents more of a holistic mindfulness, relaxation, mind-body connections. And hopefully you will find her maybe after this session, because she has lots of incredible resources for you guys that you can access online and download and have it. So this would be something also that can be used to address sadness and anxiety. Now, when we start talking about going to a psychologist or a therapist, cognitive behavioral therapy usually is something that we choose. So let me give you an example here. Imagine that you are on a highway and the highway is under construction, actually. You have a meeting. The meeting is at 9, you have 10 minutes, you always make it. It's under construction, but it's okay. You're on it, you get you join the highway, and there is a car in front of you that's going very slowly. Just one car, that's not traffic, but this car is going slowly. You're gonna be late. You're gonna be late. There's no other option. How do you feel? Anxious. Anything else? Angry, frustrated, right? Pretty frustrated. Okay, construction is over, and you can finally pass the car, and you give a look to the driver, and you see that this is actually your beloved neighbor whom you encouraged to drive to the pharmacy by herself because nobody is helping her really. She can do it. She can still see well. She drives well. You told her, just go slow. How do you feel? Embarrassed a little bit, right? Maybe not as angry, still a little bit frustrated, but the emotion has changed, right? The situation hasn't changed. You're going to be late. the emotion changed. Why? Because you interpreted the situation differently. You took under consideration more information. So that's what CBT is about. We talk about feelings, thoughts, and behaviors that are interconnected. What happens does not necessarily make us feel a certain way. It's how we interpret the situation. So that's where the work comes in. And we have several tools to do it. Oops, this was the wrong way. Here we go. We try to grab onto the negative thoughts, like the thought, I have to be on time. They're going to kill me. Well, it's not a healthy thought. It may be a rational thought, but it's not healthy. It's not helping you because you cannot speed up the car. We challenge the thoughts. Will it really be such a catastrophe to be late? We reframe it. So we try to put a balanced emotion in there. Well, it will be your first time you're late, or this, you'll just go and apologize. It's not such a big deal, maybe. We try to work with behavioral activation so engage in positive activities. My example doesn't work here, obviously. Well, you could driving. Maybe you could chew some gum to stop thinking about being late for your meeting. And we work on learning coping skills, relaxation, mindfulness, everything that. And grace. I'm sorry, but your label is not. Thank you. Is not on the right way. Yes, thank you. So that's what cognitive behavioral therapy is about. And obviously, we're trying to be supportive when you come to therapy. I don't know if you had experience with therapy or not, but it's usually a question of fit. So if you had a negative experience, maybe it was because you didn't really gel with your particular therapist. So sometimes it's worth to try again, if possible. And Dr. Jones will take us into bigger guns.
Well, I don't know about that. It's the antidepressant medications are a very important important treatment tool, but I tell people it's kind of like a pair of shoes. It's a really important part of your outfit. Your feet are going to hurt, or you're not going to feel very good if you're going all day barefoot. However, if you are only wearing a pair of shoes and nothing else, you're going to get a lot of weird looks, right? You're probably still going to be really cold or uncomfortable. So, medications are there as part of the treatment plan, but, even as someone who, my area of expertise is managing medications and helping people with medications to manage depression, anxiety. I really try to encourage the people to have realistic expectations about them, that they can kind of help, maybe open the door, but you still have to walk through the doorway, and like they were part of the treatment plan, but not the whole thing. And so, the psychotherapy, especially like the cognitive behavioral therapy that Dr. Rempala mentioned, is a very important part of treatment that, I almost always encourage all my patients to consider, regardless of what they decide about medications. However, if, for a lot of people, medications are still a very important and can be a life-changing part of their treatment plan. And for depression, anxiety, the most common medications we use are actually the antidepressant medicines. So even though they're called antidepressants, they're actually our best long-term treatments for both depressive disorders and anxiety disorders. Now, they are delayed in onset. They can take 6 to 8 weeks to reach their full effect. And sometimes they can take even longer than that because we need to increase the dose slowly and watch for side effects. And so it's not something that happens overnight. Kind of the analogy I use is that it's kind of like watching your hair grow. If you look in the mirror every day, you're not going to notice a difference. But if you look in the mirror, a month after getting your hair cut, you might say, oh yeah, I do look a little bit different. Or, a month after starting an antidepressant medicine, you might say, oh yeah, I do feel a little bit lighter, or it's, a little easier for me to function in conjunction with, using the skills that my therapist is teaching me. And the antidepressant medicines, they are one of the good things about them is that they're non-addictive. They're not habit forming. We still don't recommend that people stop them on their own without talking to a doctor, but they're non-addictive medications. And one of the other things that, especially as a cancer psychiatrist, one of the things that I focus on is trying to help address as many problems as I can with a single medication, and using what I call kind of side benefits. So, for example, a lot of antidepressant medicines can actually help with chronic pain or neuropathy. There are some antidepressant medicines that may help with insomnia. Again, like I said yesterday, none of our medications are as good as CBTI, cognitive behavioral therapy for insomnia, but some of our antidepressants can also help with insomnia. Some of our medicines can help with fatigue. Some of our medicines can help with nausea, loss of appetite. So, interestingly, a very common anti-nausea medicine that's being used with chemotherapy regimens nowadays by oncologists is olanzapine, which actually originally was an antipsychotic medicine. But if you look at, kind of the antipsychotic medicines and the anti-nausea medicines, structurally, they're all very similar. And so in some ways, the idea of a psychiatric medicine is kind of a misnomer. It's kind of, we label something as psychiatric medicine if that's what it was first used for. But the reality is that these medicines, they don't follow rules and they don't care about how we as humans categorize them. They work on things all through our body. And so, lots of medicines that, are considered psychiatric medicines can have benefits, for other conditions as well. I work with a lot of breast cancer patients who are receiving, hormonal treatments for their breast cancer. And one of the unfortunate side effects is hot flashes and night sweats. And there are several antidepressants that can be really helpful for reducing hot flashes. And so, when I'm working with the patient and trying to pick the right medication for them, I'm taking all these things into consideration. What other symptoms, treatment side effects, and issues are you struggling with? And can we find a medication that addresses as many of your, both, psychological and physical symptoms as possible with a single medication? And then even though we use antidepressants primarily to treat anxiety disorders, there are anxiety medicines or anxiolytics. They come in many different classes. They tend to be more rapid acting, but there's oftentimes greater risk of side effects, things like sedation, dizziness, confusion. And some, but not all, also have a risk of tolerance and dependence, or, unfortunately, in some rare cases, even addiction. So, again, especially when people are struggling with like a lot of anxiety, I especially emphasize the importance of psychotherapy and cognitive behavioral therapy to help them kind of change their relationship to the stressors, because the reality is that, the stressors that are in front of you, they're not going to go away just because you take a medication. And so, these medicines are a very important part of a person's treatment plan. And, I definitely don't want people to think that they are useless, because, absolutely they can be a life-changing part of someone's, treatment plan. But at the same time, you also have to acknowledge that they're not the whole outfit. They're not the whole treatment plan. And so they have to be used in conjunction with, healthy diet, exercise, good sleep, working with, a cognitive behavioral therapist, ideally, or incorporating other ways to try to help with correcting kind of these kind of negative thought patterns and behavioral patterns. And so I think that's all we have as far as prepared content. So would love to open it up for discussions and at this point.
I'm going to run this mic around. If anybody has a question, I'm going to take you, and then maybe there was a hand back there.
Thank you. I have a number of questions, but I'll limit it. But first, since I have the floor, I want to highly endorse Ian Grace for the videos that she has. Very helpful. And I want to also, yes, I agree. And I also want to highly endorse sleep psychology. My wife went to a sleep psychologist, and it helped her a great deal. My question is this. What are your thoughts, or do you have any thoughts about like over-the-counter type of stimulants or caffeine, St. John's wort, other crazy things? What are your thoughts?
No, that's a great question. I'm glad you brought it up. There's a lot of over-the-counter medications that are commonly used for things like sleep or wakefulness, things like that. I generally recommend avoiding the over-the-counter sleep aids, especially they're oftentimes made of diphenhydramine, which is the same active ingredient as Benadryl, or a very similar compound. And those do help with sleep in the short term, but people can develop tolerance to them very quickly. They can also cause a lot of really unwanted side effects, especially in older adults, such as like confusion, dry mouth, constipation, even like urinary retention. So I don't recommend long-term use of like over-the-counter sleep aids. St. John's wort does work in a similar way as a lot of our like antidepressants. We think it probably works on increasing serotonin. But unfortunately, the issue with a lot of these herbal supplements is that they're not regulated, and so it can be hard to know like what's in it. And the other thing is that, for example, like St. John's wort in particular, actually has a lot of very serious drug-drug interactions with other medications. And so if you're taking it, it can impact other medicines that your doctors are prescribing for your other conditions. And it's not just St. John's wort, but there's lots of other herbal supplements that when my patients are taking them, I always have to like check with a pharmacist, and they have to like look up, kind of the limited research that's out there. And a lot of times they do find, various drug-drug interactions that are impacting the levels of, the other medicines that they're taking. And so, I always recommend caution with herbal treatments. And the other thing is that if you do decide to try herbal treatments, I tell people always talk to your oncologists about them first. Always talk to your, PCP or other medical doctors just to make sure that there's no harmful interactions that you could be running into. Yes.
You probably noticed the accent. So I'm from Europe, and we have slightly different tolerance for herbal supplements. But everything that Dr. Jones is saying, obviously stands, but we do have many more combinations. The St. John's wort, I would be careful because it also makes you photosensitive. So, you would have to avoid sun and stuff. And but, things like the lemon balm is a good and at least in Europe, it's considered very, very safe for pregnant. Lemon balm, it's Melissa, I think, in Latin. What I would recommend, because you mentioned both stimulants and sleep aids, right? You're kind of mentioning both. I would recommend leaning into your circadian rhythm, learning about it and leaning into it. Because basically, now we know that maybe right after we wake up would be best to drink water with some electrolytes to hydrate the brain and not necessarily grab coffee. Coffee should come later because your cortisol levels anyway are up in the morning. So why don't you just hydrate and wait hours, some people say 90 minutes, and then go with coffee. Like this, you will use the cortisol that your body produced to get you up and running. And then you also will add coffee to it, and you'll basically will not waste that initial cortisol levels up. But there's lots is written, and there's lots of information on how to use your body's clock, what to emphasize, exercise either in the morning or in the afternoon, raising your body temperature about 4 hours before going to bed. These are all very, small gestures, but quite powerful. And probably, Grace, you know about them, and you talk about them probably in your program.
Yeah, definitely. And absolutely. These approaches can be integrated into, more traditional medical treatment. And, I'll have a lot of patients that use them successfully. And so, I definitely don't want to necessarily say, you can't do it. It's just
caution.
You just have to, take the appropriate precautions, talk to your medical doctors. I even have patients that, for example, I will recommend that they try over-the-counter melatonin, or I have a lot of patients that have found benefit from magnesium supplements for various issues like hot flashes or insomnia. It's absolutely, it's not an all or nothing thing. It's just you just have to be appropriately cautious when approaching it and do it in a way that's incorporates your whole picture.
Okay, we have a question from Mary back here, and also we're going to have to do a whole webinar again on supplements alone because we get so many questions. But this is from Mary, and then
Along those same lines, I don't know your opinion about CBDs or CBN, especially for sleeping and some of that THC stuff. I do know the St. John's Wort and Zandenberg, it is on the list of no. But
Sleep Foundation has on its website, if you Google CBN and THC, CBD, CBN, if you Google all three, there is a new, recently updated, I think very recently updated article on what we know about that. CBN, we know the least. So at this point, no safety information and not really just speculation that it may be helpful for insomnia. But I strongly encourage you to go to Sleep Foundation. Consider your sources, obviously. And when you will Google CBD, CBN, THC, oh my gosh, you'll get the whole list of advertisers. So you want to go to the Sleep Foundation website. Sure.
Mine is a little less of a question, a little more of a personal plug. So when I was first diagnosed, my doctor said I should see a therapist, and I lived on this earth 54 years, never saw a therapist. But I did. I went from the first month of diagnosis. And in the beginning, I realized that the reason why it's important for us to really, our community of WMers, is we are in this for the marathon. That's it. We are not sprinting. This is like an open-end cancer. So I'm coming close to ending my treatment, and my therapist said to me, would you like to stop? And I said, on the contrary, because once I close the door, and I think in our last presentation, they spoke about that, it really will bring me another set of anxiety because I'm thinking, I don't know when it will come back. Different than other cancers that you might take out surgically, may zap it with chemo completely. Of course, those people are always worried when they go for scans. But for us, it's forever. So if I could just, somebody that never went to therapy and went to it and did connect with my person, it just allows me to not dump all of those anxieties on my family. And it allows me to leave it with someone else. And so if you've never done it before, you're never too old to start therapy.
Thank you for sharing this. Thank you.
So often with CBT, or cognitive behavioral therapy, the framework is for the client or patient to enter the office and have an agenda, or be ready to tell the therapist what's on your mind. Many people who go to CBT will say something like, "I'm paying you for this. I'm not paying to have to come, with an agenda ready or to have my own solutions." So this idea of self-efficacy in therapy is kind of counterintuitive when you are paying a therapist. So what advice would you give for someone who is frustrated because they go to the therapist and the therapist just stares at them, waiting for the client to start the conversation?
I would say it's a poor fit. Honestly, and I don't know if you're, from what experience you're speaking, on what side of the couch you're on. But I would say it's a poor fit because it's a relationship. If the therapist really wants an agenda from the patient, I cannot even imagine a situation that you're describing. So it must have been a very, very poor fit. Do you have any comments on it?
Yeah, I agree.
Does it sound like CBT?
No.
It sounds like non-directive supportive therapy, which is a different approach, which basically is, well, what are you bringing today? And some people really dislike CBT because it comes with manuals very often and homework. And actually you come in and I ask you, did you do your homework? And a lot of treatment is happening outside of the room. While in dynamic approaches, most of the treatment, I think, is supposed to happen in the relationship with your patient, with your client. I was trained in both, so that would be my professional opinion.
I have a question on if you're in a major depressive disorder for an extended period of time, it must change your brain chemistry somehow. Question is there a particular part of the brain that is impacted by this? And then what kind of chemical changes happen such that the medications can be adapted to attack those?
Yeah, it's a great question. So when someone has major depressive disorder, what kinds of, chemical changes do we see in the brain, or what other, kind of physiological or anatomic changes do we see? I think it's a very complex question because what we know as major depressive disorder is probably a bucket of dozens of different unique diseases that we just can't really differentiate right now, but we know them because they have a common end presentation. They show up the same way, they appear the same way. But I think my hope is that, kind of in my career, we'll be able to subdivide like major depressive disorder into additional subtypes. Because, I think that right now, a lot of psychiatric diagnoses are based off of signs and symptoms that the patient is displaying. There's very few things that we have, like, for example, a blood test for or a biomarker for. There's a lot of research being done to change that. But right now, this is kind of the best we have at the moment. And so, I would say, the caveat is that, like, everyone's major depressive disorder is potentially very different, very unique. There could be potentially different, neurotransmitters and other issues at play. Things that we do have some theories like that serotonin is involved, and that's why, like, serotonin, many of the antidepressants that we use, they seem to increase serotonin levels or work on serotonin receptors. But there's also a lot of other potential mechanisms that we don't fully understand, like the role of inflammation. So if someone has inflammation in the body, that also impacts the brain, and inflammatory markers can enter the brain and impact brain cells. Other things like the gut-brain, microbiome, the gut-brain axis, that's an area of exploration, and things that, we think that the bacteria living in your gut can also have an impact on, your brain function. There absolutely can be, like, neurological or physical things. So for example, if someone has had a stroke affecting like a particular area of the brain or a circuit of the brain that regulates mood, you can see depression-like symptoms. So I think the answer is it's complicated. It could be a little bit of everything. And we just don't quite know right now kind of which is which at the moment, but we do have a lot of theories and a lot of active research being done in the area. And yeah, then there are like brain scan studies that do show like differences in people with major depressive disorder. But, unfortunately, it's not something that we can use clinically, like at the bedside yet.
Imagine that there is a river of dopamine flowing constantly in your brain. So not just serotonin and other transmitters, but, this is just a glimpse, right? So imagine that there's constantly a little bit of dopamine flowing, and dopamine is supposedly is helping us to move toward things, motivates us. And that river responds to our expectation. If I expect that this is going to be a good apple, I actually am more likely to go and take it. But if I expect that this is a rotten apple and probably has been growing, somewhere far away and traveled, 6 days or 6 months, I don't want it. I will not get that increase, a tiny little increase in dopamine. And that's also part of the brain functioning that affects depression and anxiety. If your expectation, so where does it live in the brain, right? We don't know exactly. It's complicated, right?
Yeah, a lot of the brain function exists in circuits, not necessarily a discrete area in the brain. And there's so many other transmitters like NMDA, oxytocin, all these things that can impact mood and brain function that we're just starting to understand.
Good morning. First of all, it's an honor to share air with both of you. Would you weigh in on the long-term use of melatonin as a sleep aid?
I would rather not. So, off the record, right? Supposedly it's not addictive. Supposedly it's not going to do much of harm. The problem is that people usually use too much of it. 1/40th of a milligram actually is already distinguished by the brain. So right now, we finally have some over-the-counters of 1 milligram, which probably is enough. I would say that extended release formulations or the patches, although the patch that I saw had 7 milligrams, and I'm thinking, goodness gracious, why do I need 7? That's a lot for melatonin. So I haven't seen really people having any problems with long-term use, but too much of it, yeah. Just because, you may get too sedated, and in the middle of the night, you're going to fall when you go to the restroom. Not necessarily from melatonin itself, but it just doesn't give you a good feeling.
Yeah.
It's not really a question. I just wanted to say that my husband died in 1999, and that was when I began therapy. And I always look at it as some of the hardest things that I have done, dealing with breast cancer, dealing with Waldenstrom's, and the death of my husband, raising my children. But I always look at it as the best present I ever gave myself, because just to have someone help me to reframe negative things into positives. Some of the worst things that have happened in my life have resulted in me walking through it and coming to the other side with a different outlook and many, many more positives. So I just want to encourage anybody who's ever on the fence that it could be the best gift you ever give yourself.
Thank you for saying that.
Thank you for that.
Thank you so much.